First of all, thank you all so much. It's an overwhelming response. And I really thank all my colleagues and my sisters. When I say sisters, is like behine, not nursing. I mean, I always say nursing officers. The seniors who have taken the immense job of actually sending out the invites and then you all coming here. Again, sincere gratitude. It's so heartening to see this. So this time, we do this World Stroke. In fact, I think there is a day for everything in the world, isn't it? There is actually, I've heard that there's a World Mushroom Day also, for some reason, which was a revelation to me that you have a day. I think the reason days are done, essentially, that there is an overall sort of, awareness amongst people in general of a lot of stuff. So when I read about the World Mushroom Day, then I realized a lot of things about these mushrooms. So it is essentially an awareness issue. When we're talking about health, I think we sort of understood the importance of health only when we went through this pandemic, isn't it? Because we all thought a lot of us feel that we are infallible, and that is true for medical professionals. Because I'm going to raise some very important questions, and let me start right now. How many of you have checked your blood pressure at least once in your lifetime? So I still see a lot of hands which are not there. So we haven't got, and I don't know whether Dr. Dipti or Dr. Ayush or Dr. Suhas have got their BP checked. So it is actually medical personnel who are most lackadaisical in terms of getting a blood test or even simple blood tests. You all take blood pressure for a patient about probably 12 times in a day, but you won't have checked your own BP, because there is this tendency that I know what to do about it when I come to it. We are aware. And this is just the reverse of what public opinion of all of us are. They feel, ये तो doctor से, ये तो nursing officer, इनको तो पता ही होगा. So when all of you work for hours together without, skipping your meals, skipping your water, you put your entire effort in because there's no other profession like ours. I truly believe in this. But people think that, so the theme for this World Stroke Day essentially is time saves lives. We've had these themes, time is brain, don't be the one, and so on and so forth. But right now it says it's directly correlating, say, look, time saves lives, every minute counts. So where else do you find this? Trauma, right? So in trauma, you have the golden hour, where every minute counts. The same thing is for heart attack, and same thing is for a brain attack. And while the golden hour for a trauma is 60 minutes, for a brain, it's also actually 60 minutes for the delivery of the important care. But then we have 4.5 hours for intravenous way of managing, and we have almost 24 hours for the clot removal techniques. But that's because of the the humongous advances which have taken place in understanding how brain functions and how to identify the brain which is dead from dying. Said that, so this will be a quick recap by our stroke personnel. Like, we are a stroke team. So it is not mine, it is not Vishnu's, it is not Dipti's, it is our stroke team's effort that we are all in it together. All of you are part of my team, our team, and we thought we should appraise each other. This is just a recap. A lot of it you already know, but then it is good to know more and get sort of kindling kind of an experience, and then do that. And I wish, even I believe the nursing the educational side that you have, the nursing college, the faculty just met me 5 minutes back that they're going to do a skit on stroke, and they're going to have the nursing students with posters. So they want to do it on a Friday, 29th of October in the OPD. So I said, you find space, go ahead. So we will need to record that. because I think that's a great effort by even. So you see, this we just designed, and it seems the nursing, the college is also doing it. So then you all can say that all of us have done this, and this program would be on a YouTube too, and we will send this little bit of a snippet even to the press. The press is coming at 1, and I will be giving that as well. So it is, but that's not important. What is important is that we are all in it together, and because stroke, and God forbid, stroke should not happen, but it can happen to one of us, and it can happen to our loved ones. So very important to know what can be done. I'm sure you can pick it up. I'm not thinking that any one of you will not be able to catch a stroke. And let me tell you this, Dr. Dipti will vouch for me for this. In her ward, there is a patient who's admitted who has a bleed in the brain. And the daughter has been associated in lot of awareness activities because of the programs which have been done. She's part of an event management team. And she was part of our stroke summer school, 3 days intensive educational program that we had just few months ago. She couldn't recognize the stroke in the father. She could not recognize it. And they went to, a close by hospital, and from there, and several hours later, when the hospital said that it is a stroke, then she landed up here. Now it's a bleed, so it's okay. But what if it was a ischemic? What kind of operation? That is the thing. What we say, we think we know. Sometimes there is a denial aspect in the brain. ये तो नहीं हो सकता. There is, and that subconsciously comes in. The second is, you don't want to look at this. You don't want to. You feel that something's happening to your loved one. It's a very peculiar psychological phenomena. Well, most of us go through that. And the third thing, of course, is being definitely negligent about what you have learned and not being able to apply. So therefore, this exercise is this. And after this, if some of you are there and then please come between 3 and 5 on 29 to the auditorium. The reason is that there we have the press coming. So there it is being covered. So there I would not only will they take bites from the faculty who will be delivering, but also they're going to take bites from the school children who've been awarded. And if you're there, then we would want your experience also to be recorded, practical experience. And that is what is more important than some didactic lectures and it's just regurgitating of what you have studied in a textbook. That's not important. So welcome you all even on the 29th. And if you could make it, please come. Okay. So that will be again helpful, as well as I think you will have an exposure to what the children also are doing, and the nursing college girls also will be there. So it will be some kind of another different kind of an exposure. Okay, though it is limited because of whatever it is, we haven't advertised it in newspaper. Again, I think pandemic has not been called off, so that thing is going on. But for us within the institute, all of us can go on at it. Okay, so with this, again, I welcome you all and thank you all from the bottom of my heart. Thank you so much for coming. It really has made my day. Thank you.
Thank you, ma'am. Good morning, everyone. It feels nice to talk to a full house crowd. I'll be dealing with the basics of stroke. For anyone, don't bother about taking photographs of the slide. I'm going to send all of you the PPT itself. Okay, so don't bother about taking photographs. You can just hear. I'll just be talking about the basics. As already ma'am has introduced, and already most of us know what stroke is. As ma'am said, we are all part of a stroke team. What happens is, if a patient may not come to us, may come to you to ask what are the symptoms of stroke, what can be done extra. I may not be able to talk to the doctor. So everyone should know what a stroke is. As ma'am said, everyone should be able to pick up what a stroke is if it happens in and around you. There might be a neighbor who is around you who may be suddenly having a neuro deficit, and when you go and see them, you must be able to pick up that this is a stroke. Chalo, we'll go take him to a stroke ready hospital, like that. So for that, we need to understand the very, very basics of stroke. What happens in stroke? Basically, stroke or a brain attack or a CVA, as we commonly call it, is a cerebrovascular accident where there is a sudden stoppage of blood supply to the brain. This is a medical emergency that needs to be treated. As ma'am said, that this is a very, very common event that keeps happening so often that close to 15 million people have a stroke every year, and it was the 5th cause of death earlier. Now it is the 2nd leading cause of death in more than 60 years old, and close to 6 million, which means 60 lakh people die of stroke every year. Every 53 seconds, someone will have a stroke, and every 3 minutes, there is someone who can die of a stroke. This was in the year 2000 when stroke was way below. Earlier, when we used to read textbooks, the most common diseases that we encountered were malaria, tuberculosis, dengue, etc. But now when we read, the most common diseases that we need to teach our children will be the non-communicable diseases. Heart attacks, hypertension, stroke. But most important among that which we are dealing today is stroke, which has a continuous rise. By the end of 2030, it will be the top 3 causes. Now, what are the types of stroke? Basically, we have 2 varieties of stroke. One is where there is a sudden stoppage of blood supply, wherein there is a clot that prevents the blood from reaching the brain. That is the ischemic stroke. There is another type of stroke when the blood vessel ruptures and there is a bleeding into tissues of the brain, which is called as the hemorrhagic stroke. So the management of both differ. Although the symptoms may remain the same, the management of both differ. Most commonly, the most common type of stroke is the ischemic stroke, which is close to 80%. That is, out of, in the ward, if you see 5 patients of stroke, most often it will be 4 patients will have an ischemic stroke and 1 person will have a hemorrhagic stroke. Now, ischemic stroke, that is the clotting of the blood clotting of the blood vessel in the to the brain, can come from anywhere. The blood clot can form in the vessel itself, which is called as a thrombotic stroke, or it can come from the heart. As most of you have worked in the ward, the first some of the investigations we write and send is the echocardiogram, the ECG. We also need to look at the heart. Why? Because we need to see if there is a source which is coming, if the clot is coming from somewhere close to the heart. Hemorrhagic stroke, wherein there can be a bleed in the brain, can be again of 2 types. One, if there is a bleed into the substance of the brain, which is the intracerebral hemorrhage. And if there is a bleed in the subarachnoid, which is the coverings of the brain, in between the coverings of the brain, if there is a bleed, is called as a subarachnoid hemorrhage. Now, among all of us sitting here, how many of us, like ma'am said, how many of us have checked our blood pressure in the last 1 week? Can anybody raise your hand? Last 1 week? 2 people. Last 1 month? Okay. So this is the thing. See, all of this is modifiable risk factor. All of this can actually be modified. If we know that we are a hypertensive and if we can take treatment, the cost of an amlodipine to the cost of a complete discharge at the time of stroke patient from the stroke hospital, I hope you can understand the difference. It is very minuscule. Treat before you actually get a stroke. These are the modifiable risk factors, of which the most important one is hypertension. Any around you, if any, there are elders, if they come and ask you, sir, what should we do? What are the what are the changes that we should do to prevent the occurrence of stroke in us? Please tell them, go check your blood pressure first. It is very important. Secondly, ask them to keep a tab, keep monitoring their blood sugars. Half of the people, when you prescribe a blood anti-diabetic agent, Most of them do not follow up with their blood sugars in your OPD. Then hyperlipidemia. Then most of us, cigarette smoking, alcohol, so many people, if you ask them in the OPD, sir मैंने छोड़ दिया, cigarette smoking छोड़ दिया, stroke कब हुआ? कल. Cigarette smoking कब छोड़ दिया? कल. This is not the way, this is not how we prevent the risk factors. They actually need to be educated. The whatever pictures that we put of cancers that happening on the label of on the box of the cigarette box, we need to put this thing of stroke also. Next, if there are other lifestyle factors, lack of physical activity, more importantly, there are other non-modifiable risk factors. The older we get, there is a higher chance we can get a stroke. Male gender, race, ethnicity, and family history of stroke. Now, what happens? This is for the very basic biochemically what is happening at the level of the brain. The moment the blood flow decreases, the tissues are unable to generate ATP. When the tissues are unable to generate ATP, the neurons begin to die. There are different levels. This is the most important aspect. Now, if there is a block, the early morning you get up, you open the tap in your kitchen, the water is not flowing. Then what do? Immediately you need to cook because the child has to be sent to school. So immediately what do? You go to the bathroom and see if the water is coming there. If the water is coming there, then that means the block is only in the kitchen. So you somehow manage with the water from there. That is exactly the reason you need to understand how much the water has stopped and from where else the water can be brought. That is the funda. Now, in the area of the brain where the blood supply has completely stopped, it is going to completely die. That region is called the core. But the area of the brain which is in orange, which is where the blood supply has reduced but not completely stopped, this area is called as the penumbra. This area can actually be salvaged back. This is the reason why that golden hour which ma'am said is very important. If there is a patient who comes, for example, a patient has come with a sudden onset weakness of the right upper limb and lower limb, and when you actually do the scan, the patient, the area of the upper limb involvement only is the core, but the area of the lower limb involvement is in the penumbra. And if you are able to give the thrombolytic agent, altiplase, tenecteplase, जो भी देते हो, the moment you give and the blood supply is re-established, the patient will be able to walk. Do you understand the difference? If the patient is not able to walk for his lifetime, then he is going to have a disability for life. If we are able to save the penumbra in that 1 hour, the golden hour, that is the most important crux of stroke treatment. What are the important D's of stroke care? Early detection of stroke symptoms. What are the common stroke symptoms? The moment you commonly see, the moment a person comes with, मुझे दर्द हो रहा है, छाती का दर्द हो रहा है, everybody knows वो directly you take him to the cardiology OPD. You know that he has a heart attack. But if I ask you, can any one of you tell me the symptoms of stroke? I can bet it more than 50% here will not know. Why? Because we don't know when to take the patient to the hospital, when to take the patient to a neurologist. That is the most important thing for us to recognize what are the symptoms of stroke. Secondly, what do we do? There is a neighbor who has developed a stroke. Next, what do? Directly call 108 or call the nearest ambulance and take them to a stroke ready hospital. Then most importantly, as soon as we take them to the triage, then what do we do next? Immediately, these are some of the steps that we will be discussing right now. Remember this acronym. Today for this seminar, remember this acronym. Be fast. You need to be fast. You need to remember be fast. Okay? Be fast is where the patient has loss of balance, can have sudden vision loss, can have drooping of the eyes wherein the angle of the mouth can become one-sided. He can have a weakness of the arm. He can have slurring of speech, essay. Then immediately if you notice any of these symptoms, even if the patient may not complain and if someone else is noticed, make sure you immediately call the emergency services and take them to a stroke ready hospital. If again, if someone asks you what are the symptoms of stroke, be fast. Got it? Be fast. The moment we take the patient to the triage, what do we do next? What should be done next? First, as we all know, any emergency patient, ABCs. Take care of the airway, breathing and circulation. And medical support. The patient's blood pressure is dropping. We need to somehow maintain the medical support, give him the IV fluids, maintain the blood pressure. Next, what do we do? The moment we know that this is an ischemic stroke, we need to thrombolyze. So, the role of intravenous thrombolysis and endovascular therapy I will be dealing with next. Patient has come, immediately there are few things that a stroke nurse or a stroke physician, the stroke doctor in the emergency has to assess. GCS. All of us, we have seen it in our wards, in our wards this has been pasted, but if out of all the nursing staff here, can anybody tell me how many of you today saw the GCS in your ward today? Very good. 3 people saw today. See, that is the difference, because we need to make sure, even though we know the GCS, we need to keep revising all this. How is the eye opening? How is the verbal response? How is the patient responding? How is his motor response? We need to check it every day for every patient. Then the next important thing is this score called NIHSS. You would have heard this when in most of the files that would have been written for any stroke patient. This is a comprehensive scale where the NIHSS is a list of set of functions, neurological functions, with each having a different score. For example, this point number 4, facial palsy. If the patient has normal symmetric movements, you ask the patient to say E. If he says E and both the side is symmetrical, you give him 0. If the patient has minor paralysis, just there is absence of nasolabial fold, you give him 1. Partial paralysis, 2. And if one side is completely not able to move, you grade him 3. Like that, different functions are assessed. This is called as the NIHSS scale. The total score of this scale is 42. Why this scale is important is because this scale, based on this scale, we say how severe a stroke is. As I said, the maximum score for NIHSS is 42. We call it as a minor stroke when the score is between 1 to 4 or less than 5. If it is, we call it a moderate stroke when it is between 5 to 15. Moderate to severe stroke when it is 16 to 20. We call it a severe stroke when it is more than 21. Most importantly, the moment a patient comes, what all we need to take care of? 1, as I said, the airway has to be protected. The patient may have a very poor GCS. Patient may have a GCS of 3 or 4, and the patient's NIHSS is somewhere 28, 30, being a very severe stroke. First, make sure the patient is alive. Before you shift him to the CT, save his airway first. Make sure his saturation is more than 94. Make sure his blood pressure is up. Give him isotonic fluids. Check his RBS. If you don't do anything, also check his RBS. You can send the investigations later, but initially, the moment the patient comes, check for the vitals, and then there are a few things which can mimic like a stroke. Today, I do not want to attend this seminar, so I'm sitting there and I'm going to say, suddenly I can't see. The person next to me, the sister next to me says, this is a symptom of stroke, chalo leke jayenge casualty. That I can act like a stroke. I may get the best national award for best actor, but I don't have a stroke. Such things are also important. These are called as stroke mimics. Sometimes a patient can have a headache, following which patient can have weakness on one side, called hemiplegic migraine. Second, following a seizure, patient can have weakness of one side of his body. This is called Todd's paralysis. This is not a stroke, but a stroke-like event. These are called stroke mimics. If there is a patient has a peripheral vertigo, we normally when patient can have actually present with a peripheral vertigo, which can also be a result of a posterior circulation stroke, or the patient can be intoxicated with some poison due to which he is unconscious and we don't know, which can mimic a stroke event, or patient can have a psychogenic disorder wherein there are other etiologies. Now the patient has come. Immediately, the first thing, what do you do in the casualty? Check for the vitals, check for the blood sugar, and immediately take him to the CT scan. Check for the vitals, check the GCS, NIHSS, check the RBS, take him to the CT. As soon as you take him to the CT scan, I'll be discussing the left half first. As soon as you take him to the CT scan, there are certain signs we need to look at. Do all patients need MRI? Definitely not. First, get a CT scan to rule out a bleed. And if you want to rule out a stroke, ischemic stroke, there are certain signs that you need to see. The 4 important signs I have highlighted here. One is focal cortical effacement. Second is focal hypoattenuation. Normally, basically look at if any area of the brain on CT is dark compared to the other side. Loss of insular ribbon sign, and this very important sign called dense MCA sign. This sign called dense MCA sign. This is the artery which, if there is a clot in the artery can appear very hyper on a normal non-contrast CT. If this is the clot, this is called as dense MCA sign. So we need to remove that clot. Now, based on this, now we found how severe a stroke is based on the NIHSS. Now, based on the CT scan also we can tell how severe the stroke is. For that, there is something called as aspect score. Basically, there are multiple points in the brain wherein you divide the brain into 2 levels. One is the ganglion, basal ganglion level, you look at the brain, and above the ganglion, you look at the brain. 2 sections you take, and in which area there is hypodensity. You mark there are specific 10 areas which you look for. If there is a gray area or a hypodensity in any of these areas, that you take it as 1 point. For example, suppose there is a black area in M5. Okay, suppose there is a hypodensity in M5. That means that out of 10, only 1 area is having hypodensity. So this is the area of the stroke. So the aspect score will be 10 minus 1, which is 9. Are you understanding what I'm saying? 10 minus 1, which is 9. So that is a low. Matlab, it's not a severe stroke. If the stroke becomes more severe, if more and more areas are involved, say for example, it is a big stroke, large MCA stroke, M4 is involved, M5 is involved, M6 is involved, then here M1 is involved, everything is involved. That means 8 areas out of 10 are involved, supposedly. Then the score is actually 2. You are getting my point? So the more severe the score, the more severe the stroke, lesser will be the aspect score. Got it? Wonderful. In the posterior circulation, again like that only, just like how I showed you in the anterior circulation, for the posterior circulation also we have a 10-point score. Okay? We need to look at the thalamus. For each thalamus we give 1 point. For each occipital lobe we give 1 point. For the midbrain we give 2 points. 2 points for the pons and 1 point each for each cerebellar hemisphere. Okay, total 10 points. If a patient has a unilateral thalamic stroke, say for example here, the aspect score will be very good. So again, larger the score, less severe the stroke. This is a large MCA infarct. You're getting my point. You understood this is the area where it is hypodense. Got it? Which I've just marked. Now, what is by definition, what do we call as a large MCA stroke? If normally the area of the brain artery supplied, which is supplying the brain, more than 1/3 of it is involved, then we call it as a large MCA stroke. Can you see the area of hypodensity here? Such strokes are called large MCS strokes. Now, the next question is, do all of them need to undergo MRI? Not necessarily. Why? Because CT is very quick. CT can be done in seconds. MRI takes more time. Or diffusion sequence will take you 2 minutes. And CT is inexpensive. This is for people working outside. Madam, no need to take photos. I'll send all PPTs to everybody. Don't worry about it. Vessels. Next important point is to look at the vessels. Because in the CT scan, to look at the vessels, we need to do a angiogram wherein we need to put a dye. Whereas in the MRI sequence, there is a type of sequence called time of flight wherein we can do the angio without giving the contrast. Now, very quickly coming to thrombolysis. Immediately the importance of the golden hour. The importance of the golden hour. As ma'am said, the stroke has to be treated within how much time? Very good. Ideally has to be treated within 60 minutes. What is the goal of giving the agent is to save that orange area which I showed, the penumbra. Very good. Not the core. The core is already dead. We can't do anything about it. We have to save the penumbra. Now, if we take more and more time, that means the core is going to become more and more bigger. The penumbra is going to be very much more smaller. So the earlier we give the agent, the thrombolytic agent, the more benefit we have. As the time progresses, the benefit and the benefit begins to come down. So we need to ideally treat it as early as possible. The highest limit that we take is usually the 4.5 hours. Okay. Now, what are the two agents that we have right now? All of you in the ward know that we have two agents which are available in the ward for thrombolysis in stroke. One is tenecteplase and alteplase. Now, alteplase is the one which is worldwide recommended for the use in stroke for up to 4.5 hours. But tenecteplase is no way inferior. You can use tenecteplase, but in India, it is recommended up to a period of 3 hours. If a patient comes to you within 3 hours, you can still give tenecteplase. The cost of tenecteplase compared to alteplase is definitely lower. Current recommendation is 4.5 hours. Now, next question is, now you see a patient, for example, an old man who is going to get up in the morning, okay? Who is going to get up in the morning and he is going to develop, he is going to say, at the moment he gets up in the morning, he is going to say, I am not able to move my right upper limb, lower limb. This is at around 4 a.m. when he wants to go to the bathroom. So you don't know what time the stroke has happened. He has slept at around 12 o'clock, but you don't know what time the stroke has happened. So in such cases, it is around, by the time he is brought to the hospital, it is say around 5 o'clock in the morning. Ideally, last we have seen him normal at 12 a.m. in the night, just before he slept. But he got up at 4 o'clock for the bathroom. It was 4 hours. By the time he came to hospital, it is 5 hours. He has crossed the limit. But now what do you do? Do you thrombolyze or not? For such cases, such cases are called as wake up strokes. The moment they wake up, they develop a stroke. You're understanding what I'm saying? The moment they wake up, they have noticed a stroke. You don't know when the stroke has happened. For such cases, we do an MRI wherein two specific sequences we need to look at. One is called the diffusion, second is called the flare. This is the diffusion image. This is called the flare image. In the diffusion, if you find this area of which is bright on diffusion, this is the area of the core which I showed you before. This is the area of the core. Now, if you do the flare, this is not seen. In such cases, when there is a mismatch, are you understanding what I'm saying? When there is a mismatch, there is a bright area seen on diffusion, not in flare. This is called diffusion flare mismatch. Such cases you can thrombolyze. Whereas if in second instance, for example, there is diffusion also is hyper, it is bright, flare is also bright. There is no diffusion flare mismatch. In such cases, you do not thrombolyze. Did you understand? Next is how much thrombolysis dose do we give? This is very, very important. Thrombolysis maximum dose for altiplase is 0.9 mg per kg. Okay, 0.9 mg per kg with a maximum of 90 mg. For example, a patient comes to you with who is 100 kgs. A patient comes to you who is obese 100 kgs. Normally, if you need to give him 105 kgs, for example, his maximum dose will be above 90 mg. But still, maximum dose you can give is 90 mg. Okay, 0.9 mg per kg up to maximum of 90 mg. Of this, 10% you give it as a bolus infusion, and then the next 90% you give it as an infusion over 1 hour. For tenecteplase, there are multiple trials that are going on, most of which have used 0.25 mg per kg as the ideal dose. Now, how do we administer? We basically take 2 IV lines. We immediately put 2 IV lines. Check again if there is any contraindication for the patient for thrombolysis. Then, as I said, you load the bolus infusion of 0.9 mg 10%. Keep monitoring the blood pressure. Do not give aspirin for the first 24 hours after you give the thrombolytic agent. Then for the next 24 hours, keep monitoring the neurological status. How do you keep monitoring the neurological status? One is GCS, second is very good, NIHSS. Okay. Do not catheterize the patient for the first 2 hours. Okay. Now, these are the contraindications for thrombolysis. Don't worry, this may not look very clear. I'll send the PPT to everyone. The blood pressure target that needs to be maintained is less than 180 to 110. When before you give the thrombolysis, there are various drug options that you can use. After you give the thrombolysis, keep monitoring the patient every 15 minutes for 2 hours. For the first 24 hours I'm talking. After that, every 30 minutes for the next 6 hours, and hourly for the next 24 hours. At the end of 24 hours, repeat another NCCT to see if there is any bleed. In between, if the patient has worsening of symptoms, immediately do the CT scan. What are the complications? The patient can develop a bleed, which can be in the brain or anywhere in the body. Brain, there is a 5 to 7% chance wherein you can use tranexamic acid, cryoprecipitate, prothrombin complex and platelets. And systemic bleeding, depending upon where the bleeding is, you can manage. There are other very rare type complications like orolingual edema, which can be managed accordingly. But most important is after 60 minutes, you have given the thrombolytic, you have given the altiplase or the tenecteplase. Patient did not improve. Patient still has a clot. Then what do? Next, you take the patient up for thrombectomy or not is the next question. You can go into the vessel, take the clot and come out and see if the patient can improve after the clot is taken out. So, who are the patients that you select for thrombectomy? For that, you do a CT angio, MR angio, and then you look at the time frame. For doing the thrombectomy, endovascular thrombectomy, now the guidelines have been extended for a period of 24 hours. Please remember, up to 1 day, if all other conditions are favorable, you can do thrombectomy for 1 day. This I'll come to later. So importantly, thrombectomy, next question is, do they give general anesthesia? Not necessarily. You can do a thrombectomy in conscious sedation only. There is no need for general anesthesia. Just like how they put a femoral line, you just puncture the femoral artery and you use a solitaire retriever. This is just a video of how they do a thrombectomy. This is the clot. First you drill through the clot. You deploy the stent, pull the clot along with the stent. This is the clot which comes back and take it out. You're getting me? This is again, you go through the clot, drill through the clot, put the stent, deploy the stent, pull the clot out along with the stent. Okay, this is the procedure for the endovascular thrombectomy. This is what ma'am said. This is the time targets that are to be kept. Okay, the first 60 minutes is the golden hour. This is door to treatment time. The patient has to be seen by the doctor in 10 minutes. CT has to be done within 25 minutes and read within 45 minutes. And the thrombolytic agent has to be, if it is an ischemic stroke, the thrombolytic agent has to be given within the first 60 minutes. If there is any other problem, then we can assess up to next 24 hours. I have described in detail. Next, what are the steps to be done will be discussed in the next. Thank you very much.
So, good morning, everyone. Anybody from outside neurology? Because we had invited the entire center nursing staff. So, सारे लोग neurology से ही हैं? Neurosurgery से हैं? Neurosciences, cardiology भी है. Okay, so, Okay, very good. So I will try to make it very simple. Dr. Suhas has rightly pointed out that his area which he had to cover was that not only our neurosciences nurses identify stroke, but as a nursing fraternity, we should be more aware than the general or the lay public about how to identify a stroke. Because if we are able to identify a stroke, we will be able to reach out to the best medical services and salvage the precious brain within time. That's one. Second very important thing which ma'am also pointed out was that we as medical fraternity should also practice what we preach. अगर हम ये कह रहे हैं कि 80% स्ट्रोक हम प्रिवेंट कर सकते हैं, आई थिंक आई टेक आउट माय मास्क बिकॉज़ आई हैव टू शाउट अदरवाइज, अगर हम 80% स्ट्रोक प्रिवेंट कर सकते हैं तो वो 80% क्या है सिर्फ ये जानना इम्पोर्टेंट नहीं है. इट्स नॉट ओनली इम्पोर्टेंट टू नो what can be prevented, but also that once we know it, we are able to practice it so that it reflects. If there is a healthy nursing team, if there is a healthy medical team, then we will be able to set a good example in front of our patients. So that is also very important. I will be talking about where the nursing staff or the nursing support we have as a team is the actual crux of the delivery of services and makes a difference in the life of the patient. Look, all said and done, we are in a hospital setting. We are not in an environment of the society. We are at our homes where we are in contact with the bigger, surroundings and planet and system and otherwise. But yes, in our professional world, we are inside the hospital and we meet people who have already suffered from the disease. Now, what can we do to save whatever we can for them is where the nursing staff is of vital importance, the paramount importance. We can instruct everything, but if it doesn't get delivered in a kind and nice and the correct way, it will not create the same impact. So the most important questions, is there a threat to life? That is what Dr. Suhas also talked about, that whenever a patient comes, or whenever you are seeing a patient or we are seeing the patient, first thing to manage is airway, breathing and circulation, ABC. So that is the most immediate threat to life. That has to be answered first. Then what are the warning signs? Now this for the nursing staff is very important, whether you are stationed in the ICU, whether you are stationed in the HDU, and even more important when you are stationed in a stable ward. That what should happen, that should warn me that look near, I should inform the doctor or I should do something about it so that this problem doesn't worsen and doesn't lead to a poor outcome of the patient. So I'll talk about it. Then when to step down care to general ward or rehabilitation. Unfortunately, we don't have very strong rehabilitation services. Around the world, there are rehabilitation hospitals. Sometimes we also feel bad for the patients that because of the shortage of beds, we have to discharge patients even when they are on a trolley, even when they are on a wheelchair, because we don't have proper rehabilitation services by which they get the confidence that with this level of disability they can be taken care of at home. But what can we do? Even if we don't have rehabilitation services, we can give the family and the patient the confidence that whatever is being told to them during their hospital stay is good enough, fair enough, so that that can be taken care of, or if that is taken care of at home, then they will be able to make their patient, make their loved one safe, as well as expedite their process of recovery. That is what we can do, and we have trials also which show that if a good home care is taken by the family instead of a rehabilitation center, that can be as good as a rehabilitation center care. Now, when to step up care? This question is also important, especially if you are in a general ward setting or in a private ward where mostly stable patients are there. What are the warning signs that tell you that, look, this patient is not doing well, this is a patient of stroke, and I have to look at this and inform or do something so that the patient gets a more intensive care and which he or she deserves. And what makes the difference? That's the final question. Is it the stroke unit bed or the mindset? Now that's very important, because you see that in NS4 and NS5 ward, we have earmarked 5-6 beds for stroke, and we say that this is a stroke unit, but invariably there are non-stroke sick patients also whom we cannot deny, and sometimes they occupy those beds. So actually it is the mindset. And the whole difference that the stroke unit makes in the difference of care between a stroke patient in a given hospital is not just the physical bed there, but also the care that we are providing extra to those patients if they have stroke. Now, we had stroke earmarked nurses also. We gave them some training, but I would encourage that all of you should at least be aware of what minimum things should be done in a patient with stroke, so that there is no problem of taking care of a patient who is admitted in the AIIMS services, even if he is not fortunate enough to occupy those 6 beds within the stroke unit. Right. So first I'll talk about, is there threat to life? So Dr. Suhas talked about blood pressure monitoring, heart rate monitoring, respiratory rate monitoring. Look, all our patients are on monitors, yes, in stroke unit, and they're beeping away all the time. What you can pick up as a nursing staff, the doctors and the patient's relatives, they are there a lot of times, but the patient's relative is a lay person. They would not be able to understand what is going on, and they would be baffled most of the times. The doctors would come at repeated intervals, but they would not stay. We have made a special arrangement where there is a desk for the nursing staff also within the stroke unit, so some of them can be actually stationed in that, physically stationed there. What's the advantage? The advantage is that if the patient has paroxysmal atrial fibrillation, there's a change in the rhythm, there are ectopics, you have a monitor which you can see, which the layperson, the patient and the family cannot interpret, but you as a nursing staff can raise a warning that, look, here there is irregular heart rate and I should inform the doctor. It makes a sea of a difference, because the management of atrial fibrillation related stroke and a normal rhythm related stroke are quite different. And that is where your role is so vital. We do a 24-hour Holter monitoring, which cannot guarantee that it will pick up all types of irregular heart rhythms. But the patient is staying in the stroke unit 24/7 for the next 5, 6, 7 days. And that gives us so much opportunity for the people who are around to pick up if there is any problem in the rhythm. Then the respiratory rate is also important, because these patients sometimes, if they're very sick and they are in the cubicle, and if there is tachypnea, then you can inform and warn that this patient might require intubation. Intubating a patient when the patient is at a later stage is fraught with more damage to the brain. Usually these patients should be electively intubated well in time. Blood sugar monitoring, temperature monitoring, intake output monitoring, these cannot be ever underplayed. They are important for all patients. So what is so important in stroke? What is important and special in stroke management is that there are set guidelines or limits within which patients have known to be having a better outcome. So if the blood sugar levels are kept, around 160 to 200, we know that they'll have a better outcome. So we try that. We do a more intensive monitoring. Instead of, just before meals monitoring, we can do a 4-hourly monitoring. Similarly, for blood pressure, if there is a sudden surge of blood pressure or if there's a sudden drop in blood pressure, that becomes a warning sign, even if the patient is the same, that something is happening in the brain which might reflect clinically later. So if such a thing is happening, then you have to inform and take charge immediately. And Dr. Suhas talked a lot about the effect or the magical effect of alteplase, stalactiplase, things which lyse the clot. Now that is a wishful thinking, that if the clot is there which has caused the stroke, if that clot dissolves and the brain is salvaged, then you have a win-win situation. Unfortunately, by the time the patient has come to the stroke unit, the part of the brain which had to be damaged has already been damaged. What we can prevent is the areas around it to have further problems, and the patient in general to have a better vital monitoring all the time so that the outcomes are better. And it has been very clearly shown that if you monitor 3-4 things, fever, okay, intake output, blood sugar, and the blood pressure, it has more impact on the recovery of the patient than just alteplase or tenecteplase. So if that effect helps you 10%, this will give you additional 30%. Now, if you can provide 30%, even if the patient has lost, that 10% chance, it's worthwhile. And you're doing a better job and a better service than even if the patient, has come to you beyond 6 hours or 7 hours or even 24 hours. So that is the difference which a good nursing care can make. So how this care is different from ICU care, I had touched upon it in the previous slide as well. So in addition to the GCS care, one is that you also monitor something which Dr. Suhas talked about is the NIHSS. That is different because it goes into a little more detail about the exact deficit that the patient is having and what you monitor. Then there is special monitoring care which you require in post-thrombolysis or thrombectomy care, which you need to be aware of, that for the first 2 hours you monitor every 15 minutes, then you monitor for every 30 minutes, every 6 hours, and then you keep on monitoring very intensively for the first 24 hours because the chances of a rebleed are more. The chances of any recurrent event is more in the first 24 to 48 hours. Now, there's a special group of patients which are again exclusive to stroke patients, which you see in your stroke units and ICUs, which are post-surgical patients. There are a subgroup of stroke patients who require emergency surgical care. And these are patients in whom there's a big stroke. Yes, we had a photograph in which there's a big MCA infarct. And in that, these patients have a life-saving surgery, which is called a decompression surgery. Sometimes if there is a big bleed which has bled into the ventricles, we also put something which is called a external ventricular drainage. You must have all seen, especially those who are in the neurosurgery ICUs, that we have patients who are later transferred to neurology, right? So they have a decompression surgery and an external ventricular drainage, depending upon the situation for which they have been managed. Now, these patients also need to be specifically managed for these post-operative situations. So for an EVD, we should know at what level it should be kept, what is the normal drainage volume that should be there. In post-decompression surgery, what is the positioning of the patient that should be there? If there is no bone on one side of the brain, how should they be positioned? So these are very exclusive and special situations which are there in post-stroke patients only. So if you are taking care of, a stroke unit, these are things which you need to be specialized or knowing about it specifically. Then positioning or changing of the patient according to the intervention, then I already told you. And then very, very simple but important thing which I keep finding is that on the parallelized side, please don't put a cannula, because there the muscle tone is down, the venous return is decreased, they are more likely to have venous pooling leading to thrombophlebitis. And if especially, I've also seen in the paralyzed limb, it is being put even in the lower limbs, that is fraught with so much of danger of this patient having a deep venous thrombosis. So the IV cannula, the IV lines should always be on the non-paralyzed or the normal side. Yes, if you're not getting it on the normal side, don't put it on the paralyzed side. Let the patient have a central venous access, but you should not put it on the paralyzed side, because that has problems. Then more prone, these patients are obviously immobile, so they're more prone to pulmonary thromboembolism as well as decubitus ulcers. Now, these are two things which are benchmarks of good nursing care. If the patient doesn't develop a decubitus ulcer during hospitalization, that I would say is a litmus test of a good nursing care. Yes? Yes, everybody agrees with that. Correct. So patient should be positioned properly, patient should have proper hygiene so that they do not develop decubitus ulcers. Then what are the warning signs? This, if you are in the stroke unit, you should know. One is any change in vitals. Any change in vitals, that could be heart rate, that could be respiratory rate, it could be a sign of a lot of things. But if you have picked it up, you have to notify it, not only document it. I feel that, your documentations are really good, but when it comes to, really transferring it to implementation, there's a communication gap which needs to be bridged. So if you're finding something, of course, document it, of course, note it, but also inform the team. We are a team here. We need to think and act together. It should not be if you're thinking something else and somebody else is thinking something else, and we think that we are going to act together, that will not be possible. Then we'll be acting differently, and then we'll be not working as a team. So if you find any problem, if you find any change, then you have to notify it to the team. Then unable to maintain saturation is always a late sign. It's too late to inform when the patient's saturation is dropping. More often than not, this is the time when, especially in the wee hours of the night, when there is a crunch of nursing staff, when there is one nursing staff for 5 patients, that is what happens. But ideally, even that nursing crunch can be, we can make up for that basically if we see that there is any sudden tachycardia or tachypnea. If we are notified at that time, if we take action at that time, then probably we will prevent ourselves from getting here and emergently intubating the patient. Then change in the sensorium. A change in the sensorium means that there is definitely something which is amiss, something which needs to be taken care of immediately. Not only you have to inform the treating doctor or the treating team, you also might have make arrangements for shifting this patient for an urgent CT scan. So, look for the orderly, look for the oxygen cylinder, try to, call for help. That's important. Okay. Now, when to step down care to general or rehabilitation? This is important in 2 ways because this is never emphasized or never emphasized enough. Because we as doctors and we all as, part of the team which is treating stroke patients, all that we think about is threat to life. We also, we kind of forget to think about what the patient and their family's perspective is towards that illness. They are thinking of the future. They are thinking कि अब इसके आगे क्या होगा, ये कैसे ठीक होंगे, ये कब ठीक होंगे, ये कब बोलना शुरू करेंगे, ये कब खाना शुरू करेंगे, ये कब चलना शुरू करेंगे. Now again, if there is a mismatch of perspective, right, that the patient's family is thinking all the time कि ये तो बेहोश है, ये तो बोल नहीं रहे, इनको जितनी भी दवा चल रही है उसका कोई फायदा नहीं है. Don't they talk to you sometimes कि इनका कुछ फायदा नहीं हो रहा है, ये ऐसे के ऐसे ही है. Yes, vis-a-vis, we are thinking, okay, in which physiotherapists have the vital role here, but yes, doctors, nursing staff, they also have a vital role because physiotherapists will tell the exercises for 10 minutes, 15 minutes, maximum 20 minutes. If they have a doubt after that, whom are they going to ask? They're going to ask you. They're going to ask the doctor. So we all should be very, very proactive and helpful when it comes to that. You have to sensitize the patients and the caregivers. Now you have managed the patient very well. There was no bed sore. Patient comes to the OPD 1 week later with a big bed sore. What have you done? You have done a good job, but not good enough. Not good enough because whatever you were doing, you have to, kind of run a running commentary. In the situation where you have the advantage of a family member, a very close member, usually a spouse or a son or a daughter with the patient, that देखिए इनको घर पे भी ले जाएंगे तो ऐसे ही करवट कराना है, इनको हर 2 घंटे पे इस तरीके से करवट बदलनी है और इनका ये पीछे पसीना नहीं इकट्ठा होने देना है, इनकी बेडशीट ठीक रखनी है. So all those things, they are very flustered at that point in time. They have too many things on hand, the family and the caregivers. They have to take care of the money which is being spent. They have to take care of the house which is left without the primary earning member and the caregiver. So they have a lot of things at hand, and they might not pay attention till the time you don't point it out to them. So when you are feeding the patient, you're putting rice tube, you're taking care of that, you're taking care of the oral hygiene, you're taking care of the bed care of the patient, you're trying to dress up the patient, change the patient's position. Then at that time, it is very important also to keep on talking to the patient and their family that this is how they are supposed to continue to do it even when the patient is discharged. And let me tell you, it makes a lot of difference. It makes a hell lot of difference, because when the patient comes to us after 1 month, 2 months, we know that the patient has been taken care of nicely just by asking 1 or 2 simple questions. कि patient की पीठ में घाव तो नहीं बना है, patient को बुखार तो नहीं. If they have taken well care of these 2 things, they are going to recover really well. And you, as the person who was taking care of these patients in the stroke team, in the stroke ICU, can sow the seeds of that good care right from the time when the patient is admitted. And there is no replacement. The other very important thing is, we are all hard pressed for time, but empathy is important. Empathy means if I was in their place. Sympathy की बेचारा बहुत बुरी स्थिति में है, खराब है. Empathy is one step ahead of sympathy. Empathy is if I was in that place, if I was next to the patient who is on a ventilator. So empathy makes a lot of difference. If the patient's family gets that signal that you are empathetic towards them, half of the problems, half of the fights, half of the complaints with the patients are solved. And that is one thing which can also make up for a lot of human errors which are done because you have paucity of workforce. कि अच्छा इसका blood sugar तो लेना था, अरे 2 घंटे हो गए मैंने check नहीं किया. You can go back and say अभी मैं ले लेता. But if there is no empathy, then that whole connection gets lost. Then even an error of 5 minutes is bad, sounds bad. So that is also one important element. Then teamwork with the dietitian. You also have a good teamwork with the physiotherapist, like I told you. And we encourage our resident and our nursing staff to have a to-do list before the patient is discharged. There has to be a to-do list कि इसका ये हमने बता दिया, ये भी हमने बता दिया, ये भी हमने बता दिया है. तो ये सब इसको पता होना चाहिए. इसको पता होना चाहिए कि अगर पेशेंट ट्रॉली पे जा रहा है तो अगर इसको छोटा मोटा बुखार हो तो इसको वापस इमरजेंसी एम्स नहीं लेकर आना है. इसको छोटे मोटे बुखार के लिए वहां पे भी डॉक्टर को दिखाया जा सकता है. These are little things, but patients need to be told categorically. So this is a big rehab circle, where you have the patient in the center. It's all patient centric. Then there are, the treating neurologists, the occupational therapists, the surgeons in some cases who saves lives of the patients, the dietitian, and the caregiver. Now the patient and the caregiver are, you can see, they're all at the receiving end of everything. So the more we give to them, the better they will take from us. Right. So to-do list before discharge. Is the patient alert? Yes or no? If the patient is alert, your job is easier. If the patient is not alert, then your job is more. So this yes or no has flipped, so it's no. So if the patient is not alert, then you have to see, can the patient swallow or is he on rise tube? If the patient can swallow, then again the job becomes slightly easier. If the patient is on rise tube, then the problem is one additional that you have to tell how to, ask the patient to give feed via rise tube. If the patient can swallow, then still these things need to be mentioned and put in the checklist. One is that BP monitoring, medications. Lot of times patients have come back कि अभी थोड़े से ठीक हो गया, हम इनको स्मोकिंग दोबारा इन्होंने जिद की तो हमने दे दी. You have to tell that this caused the stroke. It has to be, and it sinks in. If the patient is in a crisis situation, if the family is in a crisis situation, that is the situation where it sinks in. That is the situation where they actually quit alcohol, where they actually quit smoking. Okay, so this is the right time to sensitize them. Then also specific instructions about anticoagulation. This is very much underplayed. We underplay it as doctors. And the nursing staff also sometimes, you know, is there is just a written instruction written that INR should be what 2 to 3. The patient is illiterate, has no idea of what INR means, what 2 to 3 means. And after 3 months, they come with a bleed in the brain or a complication, or they've stopped medicines because they don't know what to do with it. So it has to be made very important that if the patient is on any anticoagulation, especially warfarin, which needs to be monitored, then they need to be told how frequently the blood investigations should be done and how should they be done and when should they report back. Then physiotherapists, therapy, and if not mobile, then DVT prevention and positioning. Okay. And if the patient is on Ryle's tube, then of course additional, you know, you have to put Ryle's tube feed instructions. If the patient is alert, then you know, you have to see if the patient is not alert. Then of course another thing that you have to see is that if the patient is tracheostomy. So that is another level of complication, right? If the patient is on a tracheostomy, and unfortunately because we have many sick patients, we also sometimes send patients on tracheostomy and sometimes even on oxygen, intermittent oxygen care. So you have to additionally tell about tracheostomy care and catheter care. And before discharge, remind the doctor and yourself, be aware of it, that the Ryle's tube and the Foley catheter both need to be periodically changed depending upon the type of catheter that the patient is on. And preferably have the patients on silicone catheter, have the patients on Frica's Ryle's tube, so that they don't need to go to the medical facility very repeatedly to get these changed. Because more visits to the medical facility means more exposure to infections, right? Then to step up care, this is one part which is important, and smart nursing team can help a big way in this. So shift the patient to the ICU from stroke unit. A lot of times we are not able to do that. We do that in the stroke unit itself, and you must have seen that because we have a very small ICU. But this is for, you know, basically generic purposes, that whenever we need to step up care for a patient who has especially undergone a life-saving surgical procedure like a decompression surgery, we should always prefer that such patients should be in the ICU care, so that there is a better nurse to doctor, nurse to patient ratio, so that they can be better taken care of. So obviously this translates into better ventilatory care. So if you think that you are not able to provide the optimum ventilatory care in the ward, then you should push that this patient requires more monitoring, probably requires sedation, because the ventilation is not getting optimally controlled with whatever measures you are doing in the stroke care. Then immediate post-op period. Sometimes I told you, patients who have undergone decompression, who have undergone external ventricular drain, they are exposed to, if they're exposed to, a lot of infected patients in the cubicle, in a crowded cubicle, they are more likely to have post-surgical infections. And all the nursing staff which has been working in neurology, neurosurgery, cardiology, any other department across this hospital knows that the problems are not usually of the stroke itself. It is usually related to the care which is given in the post-op period, leading to hospital-acquired infections. Patients usually don't succumb to immediate, stroke-related complications. They eventually succumb to ventilator-associated pneumonia, to septicemia, or hospital-acquired infections. So those are things which can be prevented if the patients are in a better environment where they are better isolated from such infections. And then, of course, complications requiring interventions and unresolving sepsis or hyperglycemia or hypotension. Usually it is a combination of all. A patient who lands in sepsis also lands in poor blood pressure control, also lands in refractory hyperglycemia, also lands in, electrolyte disturbances and kidney failure. And then there is this cascade of complications coming up. So if you see that happening, then probably we need to raise an alarm that the care needs to be stepped up. And then, of course, the last and the most important part is, of course, the mind and the mind. There's no, doubt about it. We know that there are elegant trials which say that stroke units work better than a general ward, definitely. but they are the same beds. They're the same people. What makes the difference? It's the mindset, right? And of course, it also means that if we really need to make a difference, we should also push that if we need to manage sicker patients of stroke, then we need to have a better nurse to patient ratio. Then we also need to have a better bed spacing. But all those things within the constraints that we work, as long as we have good awareness about them, I think we can make a difference. And over a period of time, I think the institute is working towards, getting there. So let's hope that we get more specialized care and more HDUs. So high dependency in specialized care, impact of stroke unit on long-term outcome. So it's not only that you discharge the patient or you change the mortality rate. So, out of 10 patients who were there in a normal stroke unit care, in a normal general ward care, let's say, you could save 6 out of them. And in a stroke unit care, you could save 8 out of them. So you saved additional 2 from dying. But patient's family, like I told you, don't look at that as the outcome. For us, the patient has survived looks like a good outcome to us. For them, 6 months later, they come with the patient on a trolley and they ask us, कि पता नहीं ये कैसे भुगत रहे हैं, So we also have to take care that can we make a difference in their long term? Can we do that? And yes, we can. I told you that if the intensive care is good, then the recovery is definitely going to be better, right? So it is driven mainly by simple things, not a rocket science. It is driven mainly by controlling of vitals, close monitoring of respiratory functions. If the patient doesn't catch and doesn't get aspiration pneumonitis, doesn't go on a ventilator because you've done proper suction and positioning, this patient is going to walk down to you after 3 months, 6 months. Vis-a-vis the same patient who aspirates and then develops ventilator-associated pneumonia, even if you are able to save the life of a patient and discharge him on a tracheostomy tube, he's going to come on a trolley. So you've made a difference. You've just made a difference by good positioning and good care of the patient, and timely intervention and aggressive monitoring, and of course, sensitization. That's very important, and that's very exclusive to our center, let me put it that way. Because around, you'll not find it in textbooks. You'll say कि patient को rehabilitation के लिए भेज दिया. We don't have that luxury. We have a setting where the rehabilitation and acute care go hand in hand. Both go together. But when both are going together, let us make it the best that we can, right? So, final common pathway of implementation of science. We know the science, but we also should understand that implementation of that knowledge and empathy towards the patient makes the magic. Gives that Midas touch, if you were to say. The only pathway for personal healing and compassion, and there's no substitute to it. And it includes the whole big team, doesn't include only doctors and nurses and physiotherapists. It also includes the patient in the center and the caregiver also with them. That has to be understood and impacts not only acute outcomes, but long-term quality. So I'll be very happy to take any questions. Thank you.
I thank everyone who has participated. I hope all of you learned something today. Yes? Yes, very good. And all of you are going to receive your participation certificates, and please kindly give us your email IDs so that we can mail it to them personally. And any questions, any feedback, we'll all be in the ward, and when we mail you, you can give us a feedback back. Okay? Thank you. We have snacks and tea arranged outside. Thank you so much.